In the mid-20th century, researchers mapped out the clinical baselines of the human sexual response cycle. They documented a sequential series of psychological and physiological states, moving from desire through resolution. We now understand erectile dysfunction, or ED, as a specific, measurable impairment occurring in the arousal phase of this cycle. That arousal phase relies almost entirely on precise vascular function. It requires blood vessels to dilate smoothly and maintain robust internal pressure. When those vessels restrict or fail to dilate properly, it impairs the blood flow necessary for the mechanical process of arousal. This timeline reveals a startling correlation. Because the mechanism of arousal is so heavily dependent on the vascular system, the onset of ED symptoms serves as an early warning marker. Localized symptoms frequently appear up to 5 years before a major cardiovascular event, such as a heart attack. The blood vessels in the penis are significantly smaller than the coronary arteries, meaning they show signs of damage much earlier. For younger men, experiencing ED is a specific indicator for future cardiac risk, predicting up to a 50-fold increase in the likelihood of a major heart event. Yet, societal shame frequently drives patients toward anonymous, online low-T clinics. These services offer chemical fixes without any physical evaluation, a choice that ignores the actual vascular degradation causing the symptoms. To address the root of this systemic threat, patients must move past quick fixes and into a rigorous, evidence-based diagnostic algorithm developed by the American Urological Association, or AUA. The AUA algorithm begins by standardizing patient inputs. To establish a clear medical baseline, physicians collect data through validated questionnaires, like the Sexual Health Inventory for Men, or SHIM. They pair this with a morning blood draw to accurately measure total testosterone levels. Before any treatment begins, patients pass through a logic gate known as the Princeton 3 criteria. This sorts men into specific cardiovascular risk categories, ensuring that any prescribed treatment is safe for their current heart health. Once the risk is established, the algorithm relies on shared decision-making. The doctor and patient work together to weigh the risks and benefits to choose the most appropriate therapeutic path. Tier 1 of the treatment pipeline focuses on non-invasive oral PDE5 inhibitors. These are the standard first-line pharmacological defenses, which include well-known medications like sildenafil. This comparison table maps out the two main dosing protocols. A patient might choose a low daily dose, which maintains a steady level of the medication, or a higher on-demand dose taken as needed. Each path has specific trade-offs regarding the frequency of side effects like headaches and flushing. For those who prefer mechanical options, this first tier also includes vacuum erection devices, or VEDs, which use negative pressure to draw blood into the tissue without the use of drugs. By utilizing the least invasive and easily reversible interventions first, the algorithm resolves the vast majority of ED cases. For patients who do not respond to oral medications or mechanical devices, the algorithm advances to Tier 2. Tier 2 utilizes intracavernosal injections, or ICI. By injecting a blend of compounds, such as alprostadil and papaverine, directly into the penile tissue, these medications bypass the systemic pathways to force direct vasodilation. Because these medications are highly potent, the algorithm mandates an in-office injection test. This allows a physician to calibrate the exact dosage needed and prevents adverse events like prolonged erections. If localized injections fail, the algorithm moves to its steinal branch, Tier 3 surgical hardware. This is reserved strictly for complete non-responders to previous therapies. This schematic outlines the mechanics of a penile prosthesis implant. Surgeons place inflatable cylinders inside the tissue, which are connected to a concealed fluid reservoir and a small pump mechanism. This final tier boasts exceptionally high efficacy rates, but it represents the absolute endpoint of the algorithm. Surgically implanting this hardware irreversibly alters the biological state of the tissue. When a patient moves from fragmented symptom management to a structured, stepped care medical approach, ED becomes a highly manageable condition. The strict sequence of the AUA algorithm ensures that both patient and physician evaluate holistic medical data rather than treating an isolated symptom in a vacuum. The mandatory hormonal panels and cardiovascular risk stratifications within this pipeline identify life-threatening vascular issues years before a fatal event can occur. Completing this shared decision-making process restores localized physiological function while securing a patient's systemic health and longevity.